Hi everybody, welcome to part 2 of Dr. Manny's YouTube Learnshops, Temporary Cardiac Pacing. As I indicated in part 1, these are for nurses or healthcare providers who care for patients who have a temporary cardiac pacemaker. What we're going to review in this Learnshop, part 2, are the NBG pacing codes, certain pacing modes, and the rationale for cardiac pacing. Let's review the knowledge again. The intrinsic cardiac rhythm refers to which of the following statements? A, B, C, or D? The correct answer is A, the patient's own heart rhythm. Question 2. Which of the following statements explains the relative refractory period? A, B, C, or D? The correct answer is D, all of the above. 3. Which of the following relate to the R on T phenomenon? A, B, C, or D? The correct answer is D. 4. Which of the following best describes the millivolt? A, B, C, or is it D? The correct answer is A, the unit which measures the amplitude on the ECG. Which of the following connects to asynchronous atrial pacing? A, B, C, or D? The correct answer is all of the above. 6. Which of the following best explains demand mode pacing? A, B, C, or D? The correct answer is A. Pacing will only occur if the heart rate falls below a set pacemaker rate. Question 7. AV sequential pacing is best explained by which of the following statements? A, B, C, or D? The correct answer is D, all of the above. Which of the following is true? A, B, C, or D? The correct answer is D. All the above are true. Which of the following then pertains to the intrinsic cardiac pacemaker? Is it the SA node, AV node bundle of His Purkinje fibers? The correct answer is the SA node. The sinoatrial node is the intrinsic cardiac pacemaker. Which of the following does the P wave represent? And the correct answer is atrial depolarization. Can you identify this pacemaker rhythm? This is atrial pacing, and it could be AOO or AAI. What about this one? This is ventricular pacing, which could be VOO or VVI. What about this pacemaker mode? This is AV sequential pacing, which paces the atria and the ventricles in synchrony. When we look at codes that are used for temporary cardiac pacing, we look at the NBG code. The N stands for the North American Society of Pacing and Electrophysiology. The B stands for the British Pacing and Electrophysiology Group, and the G is just the generic pacemaker code. And this was a joint project of both the North American Society for Pacing and Electrophysiology, NASPEC, and the British Pacing and Electrophysiology Group, also referred to as BPEG. And they came up with this modified code in approximately the year 2002. more than 18 years ago. The first letter in the code is for chambers paced, which could be the atrium, the ventricles, or both, dual. The second letter refers to chambers being sensed, which could be the atria, the ventricles, both, dual, or none. The third letter refers to the response to sensing, which could be inhibit, trigger, dual both, or none. Modes for cardiac pacing then basically are asynchronous, fixed mode, AOO, VOO, DOO. Synchronous is demand mode, which could be VAT, VDD, DVI, DDD, or DDI. Single chamber can be AOO, AAI, VOO, VVI, and dual chamber can be DDD, DDI, DVI, VAT, or VDD, which we'll be looking at as we go through this program. AOO is fixed mode. It's asynchronous, and it paces the atria. There is no sensing available. VOO is fixed mode, asynchronous. It paces the ventricle. There is no sensing available. DOO is fixed mode pacing. It's asynchronous. However, it paces both the atria and the ventricles, but if there's any inherent atrial or ventricular activity, no sensing is available. The pacemaker will not recognize it. AAI is a synchronous pacing mode, and it paces the atria, and if it senses inherent atrial activity, myopotentials, beat, then pacing will be inhibited and stopped, and the heart will be allowed to do its own thing, as you can see there in the second beat. VVI paces the ventricle, and if it senses inherent ventricular myopotentials, activity, beat, then pacing is inhibited, stopped, and the heart can do its own thing, as demonstrated in the third beat. VAT is a mode that paces the ventricle, and if atrial myopotentials are sensed, then it triggers ventricular pacing to join. Have a look at the fourth beat there. The atria was sensed, second part of the code. The pacemaker said, hey, there's a P wave there, atrial myopotential, and it triggered to join after a certain period of time, the PR interval, with ventricular pacing. This is VAT. Then you've got VDD, and VDD paces the ventricle, and if atria or ventricular myopotentials are sensed, then it triggers or inhibits ventricular pacing. So you can see in that beat there, it sensed atrial activity. It didn't sense any ventricular activity. So therefore what it did, it joined the ventricular pacing to the P wave at the end of the PR interval, which is pre-programmed, and it provided atrial and ventricular synchrony. Also did it on that last beat. If it had have sensed ventricular activity, then you'd see a normal PQRST complex there, but there's none in this rhythm strip. VDD. This is DVI, and DVI paces both the atria and the ventricles, and if the ventricular myopotentials are sensed, then it will inhibit ventricular pacing. As it says in the code there, ventricular sensing, it will inhibit pacing and let the heart do its own thing. What we're seeing there in the rhythm strip, however, is total atrial ventricular sequential pacing. Obviously there are no inherent heartbeats there. or myopotentials. DDI paces and senses both the atria and the ventricles, and if atrial and ventricular myopotentials are sensed, look at the code, D, second letter, then it will inhibit, third letter, response to sensing, atrial and ventricular pacing. In this rhythm strip, however, it is atrial and ventricular pacing. There is nothing being sensed. DDD paces and senses both the atria and the ventricles, and if atrial and ventricular myopotentials are sensed, then it triggers and or inhibits atrial and ventricular pacing. Have a look. There, it's inhibited both because it sensed atrial and ventricular myopotentials. Here, it only sensed atrial myopotentials, no ventricular, so it paced the ventricle. Over here, it didn't sense any atrial myopotentials, but did sense ventricular myopotentials. So it only paced the atria, not the ventricle. And over here, it sensed both atrial and ventricular myopotentials and didn't pace either. So what's the rationale? What's the rationale for cardiac pacing? Why do we want to do cardiac pacing that is temporary? Well, this can be for symptomatic bradycardias, AV conduction disturbances, which we refer to as heart block, tachycardia dysrhythmias, cardiac rhythm syndromes, and prophylaxis, just in case. So when we look at symptomatic bradycardias, we can look at bradycardias such as, we can look at any bradycardia that is hemodynamically unstable. Heart block, this is an ECG with third degree AV block, heart block, which again is potentially hemodynamically unstable. The heart rate is approximately 30 beats per minute, and this would be hemodynamically unstable. Then you've got AV conduction disturbances, which we said could be heart block. And this is AV dissociation, which means the atria and the ventricles aren't working together, and this could be a bradycardia. The heart rate in this situation is about 30 again. Then you've got tachycardia dysrhythmias, such as supraventricular tachycardia, which could be AV nodal reentry tachycardia, to try and get control of the heart rate, because as we mentioned previously, most pacemakers have a function called overdrive pacing, and this heart rate at the moment is approximately 180 beats per minute. So therefore the pulse generator, as I indicated earlier, can go up to 300, 400, 500 depending on the pulse generator, and this can take control of the heart rate and bring the heart rate back down slowly to where it should be to stop this atrial dysrhythmia. Then you've got cardiac rhythm syndromes, such as long QT syndrome, which can result in torsades de pointe. And with low QT syndrome, then here the pacemaker can take control of the heart rhythm and try and avoid this from happening. And they may end up requiring a permanent pacemaker. Then you've got prophylaxis, just in case. The patient keeps having sinus pause, which could result in sinus arrest, which could eventually become asystole. So do it just in case. I mean, this could be, let's say, for example, overdose of a beta blocker, calcium channel blocker, a medication of some kind. Or it could be related to certain conditions such as hypothermia, which eventually the patient will warm up. A temporary measure, prophylaxis, just in case. Or it could be related to medication refractory dysrhythmias, which means, gee, the patient's gone into this rhythm, a bradycardia, for some reason. They're not responding to atropine. They're not responding to a sympathomimetic like epinephrine. They're not responding to medications that we can give them by infusion like dopamine or dobutamine. Unresponsive bradycardia could be one. Okay, that's the end of part 2. Thanks again. If you found this of any value, please continue to part 3 and recommend it to your colleagues. Thanks.